Bismillah ar-Rahman ar-Rahim. Today I will speak to you about the first lecture about in heart failure. I will start by heart failure definitions and types. The definitions of heart failure started very early in the last century when Thomas Lewis in 1933 described heart failure as a condition in which the heart fails to discharge its content adequately. So it was mainly related to the ability of the heart to discharge the blood from inside it. Then Paul Wood in 1950 described heart failure as a condition in which the heart fails to maintain adequate circulation for the need of the body despite satisfactory filling pressure. So the first time to mention the idea of the importance of filling the pressure to maintain adequate cardiac output. Eugene Proud in 1980 was the first well-formed definition of heart failure when he describes heart failure as a pathophysiological state in which an abnormality of cardiac function is responsible for failure of the heart to pump blood at a rate commensurate with the requirement of the metabolizing tissue. So Eugene Proud linked the importance of maintaining cardiac output to the needs of the metabolizing tissue, and this deficiency of cardiac output defined it as heart failure. The first link between heart failure as a clinical syndrome to be included in the definition was in the ACC 2009 when they describe heart failure as a complex clinical syndrome that can result from any structural or functional cardiac disorder that impair the ability of the heart to fill or eject the blood. Then the well-formed definition was reached in the guidelines of 2016, ESC heart failure guidelines, when they define heart failure as a clinical syndrome characterized by symptoms of volume overload, breathlessness, and low output fatigue, accompanied by signs of volume overload, namely ankle edema, elevated GBP, pulmonary crackles, and peripheral edema, caused by structural and/or functional cardiac abnormality. So they included the cause in the definition, and the end result is reduced cardiac output and/or elevated intracardiac pressure at rest or during stress. So they separate the pathophysiology of heart failure into either low cardiac output, which we know this is the half ref, or elevated intracardiac pressure at rest during the exercise, which is the increased filling of pressure, which is the half ref. The best definition and the shortest definition now is the Canadian guideline definition in 2017, where they consider heart failure a complex clinical syndrome in which abnormal heart function, either physiological or either functional or structural, result in or increases the subsequent risk of clinical symptoms and the signs of reduced cardiac output and/or pulmonary or systemic congestion at rest or with stress. So the patient might be asymptomatic at rest, and once he starts exercising, he starts to show symptoms. Is it acute or chronic? It's either of timing. Chronic disease means chronic heart failure means the resistant and the progressive nature of the disease, but acute heart failure is a rapid or gradually changing heart failure symptoms and signs, but necessitating the need for urgent therapy. Once the patient presented to the ER or the hospital with acute symptoms of dyspnea and shortness of breath, this is acute heart failure. The ACC also did major step in the definitions of heart failure when they classify heart failure to stages: stage A, stage B, stage C, stage D. Actually, stage A and stage B are not showing any heart failure symptoms, but they are pre-heart failure state. The stage A is the stage of risk factors, just diabetes, hypertension, atherosclerosis, obesity, metabolic syndrome, no heart failure symptoms at all, and there is no evidence of structural heart disease. This is stage A, the stage of risk factors. Patients who are high risk develop heart failure in future. And then stage B are patients who are having structural heart disease, but there is no heart failure symptoms yet. We call them stage B, like patient with asymptomatic LV dysfunction due to myocardial infarction, for example, or patient with concentric left ventricular hypertrophy before the development of any symptoms. So this is stage B heart failure. And then we have stage C heart failure when there is symptoms of heart failure, either now or prior heart failure symptoms. Even if the patient had heart failure symptoms and he now is asymptomatic, this patient is stage C. So any prior or current heart failure symptoms are considered stage C. So stage C never go back to stage B, and it's only one way direction. Stage D are refractory, are patients with refractory heart failure symptoms who always symptomatic, always in severe symptoms. Those patients are, we call them stage D heart failure or refractory heart failure, or sometimes we call them advanced heart failure, patients who need advanced therapies like CRTD, like LVAD, like heart transplant, or even palliative hospice care. If we included the ACC-HA staging of heart failure with the NYHA functional classification also, we're gonna know that patients with stage A are the stage of risk factors. There is no symptoms or signs at all of heart failure. And the stage B, or they are in NYHA class 1, there is no limitation of physical activity. There is only, we call it asymptomatic LV dysfunction or asymptomatic structural changes in the heart. Stage C could be in stage 1 if he had recovered heart failure, but usually he's in stage 2 or stage 3, and a small number of them may be in stage 4. But the majority of stage 4, NYHA stage 4, NYHA class 4, sorry, are in stage D. So stage D usually include most of NYHA class 4. Regarding the ejection fraction based definitions, the last ESC guidelines classify heart failure into half ref and half BEF, and in between there is a new group called half mid-ref, half M-ref. What does this mean? Half ref, everyone know that it's heart failure with reduced ejection fraction, and the half BEF is heart failure with preserved ejection fraction, and the half mid-range is MR, half mid-range ejection fraction. What does this mean also? If the ejection fraction below 40, this is half ref, above 50, this is half BEF. Between 40 and 49, this is half MREF or half mid-range ejection fraction heart failure. For half ref, just we need the symptoms and signs and the evidence of low ejection fraction. This is enough to diagnose half ref. But for half MREF and for half BEF, we need the symptoms and signs plus evidence that the ejection fraction above 40, either 40 to 49 in half mid-range or above 50 in half BEF, plus some other criteria. What are these criteria? This criteria, number 1, include elevation of the natriuretic peptide is part of the definition of this syndrome, and also some structural heart disease by echo, like LVH or left atrial enlargement, and some diastolic dysfunction parameters related to the E wave and the E over E prime waves. So the Canadian heart failure guidelines also put the same classification: half BEF if the ejection fraction above or equal to 50, half REF if the ejection fraction below or equal to 40, half MEF, half mid-range ejection fraction, but they remove the R, so they put half MEF. So it's going to be easy, just 5 letters: half BEF, half MEF, half REF. And they put ejection fraction between 41 and 49, not 40 and 49, but 41 and 49. And this goes with the American classification. So what do you need to have half ref? Just you need to have the symptoms and signs and the reduced ejection fraction. For half BIF, you need the symptoms and signs and BNB and this relevant structural heart disease abnormality. The ACC-AHA, they put classification more or less similar, but instead of saying half mid-range, they said half BIF borderline. So they put this this group between 40 and 49 as half BIF but borderline, and they consider them mainly behaving like half BIF. But unfortunately, this is sound not right. Why? Because we know from the last study, the Paragon heart failure study, that most of those patients behave like half RIF, mainly not half BIF. So considering them as half BIF borderline, little bit not good. We can say half heart failure B خفيفة يعني borderline ejection fraction, but not say half BIF borderline. And it is actually what we have put in our guidelines, in the Saudi heart failure guidelines, which I am part of the faculty who wrote this guidelines. We put half B بخفيفة half BIF but بخفيفة مش تقيلة. Etiology of heart failure in the last guidelines, it's very easy now to diagnose the etiology of heart failure by classifying it to either disease of the myocardium or abnormal loading conditions and arrhythmia. So we have three main causes of heart failure: either disease of the myocardium, number two, abnormal loading conditions, and number three, arrhythmias. Disease of the myocardium including ischemic heart disease, whatever the etiology, toxic damage to the heart, whatever the etiology, alcohol, drugs, anything leading to toxicity, and immune-related, either disease, immune-related disease, or even infections cause an immune reaction, including viral myocarditis, and infiltration as well, including either malignancy or any kind of infiltration like amyloidosis, for example, hemochromatosis, or metabolic derangement, including hormonal like thyroid and others, and nutritional like selenium, like L-carnitine, like thiamine deficiencies. All these included in the metabolic, genetic abnormalities, including glaucoma, ARVD, and others. And then abnormal loading conditions, including valve disease, hypertension, congenital heart disease, pericardial disease, endomyocardial disease like endomyocardial fibrosis, hypereosinophilic. All these are included in the abnormal loading conditions. Lastly, arrhythmia is going to be tachyarrhythmia and bradyarrhythmia. All of them can cause heart failure. The symptoms are either typical symptoms or less typical symptoms. The typical symptoms are restlessness or apnea, PND, reduced exercise tolerance, fatigue, tiredness, angioedema. But there are also less typical symptoms that should be raise our attention about heart failure. Either the patient has nocturnal cough, some GIT manifestation, depressions, confusion, dizziness, whatever. Also, there are typical signs of heart failure like elevated GVP, hepatic reflux, third heart sound, and displacement of the apex laterally is one of the typical signs of heart failure. But less typical signs like abnormal weight gain, weight loss, cachexia, cardiac murmur, hepatomegaly, all these are less specific signs of heart failure. How to approach, how to diagnose patient with heart failure. Number one, the history is the most important, especially if there is history of myocardial ischemic heart disease before. It's very important to elicit. And also the symptoms, history of the symptoms, very important. And then this typical signs, as we mentioned above, and then the ECG. ECG usually abnormal in patients with heart failure. It's unlikely to have patients with heart failure with normal ECG. If these criteria are all present, then you can go directly to echocardiography to diagnose heart failure, either with to be half BIF or half RIF, whatever. But natriuretic peptide now is an essential step in the diagnosis, even before the echo, because you can roll out many heart failure, many cases as heart failure from this step. So if the NT-proBNP or the BNP is extremely low, you can exclude heart failure by a very high negative predictive value. So heart failure is unlikely if we have extremely low NT-proBNP or BNP. But if it's high, then you can consider heart failure as an etiology. If it's very, very high, then this increases the sensitivity of the test. When we go to the hemodynamics, it's important in the emergency room, if we have heart failure patient, to classify it into these 4 groups. Is the patient warm and dry? Is the patient warm and wet? Is the patient cold and dry? Is the patient cold and wet? What does warm and cold mean? This means the patient is either well perfused, can it be warm, or not perfused, hypoperfused, can it be cold. If the patient is wet, means he is volume overloaded, or the patient is dry, means he is not volume overloaded. Most of our patients in the acute heart failure setting, we saw them in this group. Warm and wet, mean the patient is well perfused, but is overloaded, volume overloaded. About 60 to 70% of patients present to the emergency room are in this category, like patients with pulmonary edema, for example. They come to the emergency room warm, not shocked, but they have a lot of fluid in their lungs. A minority of patients will maybe present as cold and wet. Those are the patients with cardiogenic shock. They are around 5% of the patients when they come to the emergency room, hypertensive, hypoperfused, and they have volume overload. The cold and the dry patients are patients who present mainly with hypovolemic shock, and warm and dry are patients who are stable in the chronic heart failure setting. The stage D heart failure patients are patients with advanced heart failure. These are the patients who are refractory to medical therapy, and they usually need advanced therapies like mechanical circulatory support and maybe continuous anaerobic infusions, maybe cardiac transplantation, and maybe other innovative or experimental surgical procedures like mitral clip, like LVAD, CRT, or even end-of-life issues like hospice care. Then the advanced heart failure patient could be, we could call them as advanced heart failure, as stage D heart failure, as refractory heart failure, or end-stage heart failure. Advanced heart failure is the most likely term we like. These are patients with advanced heart failure state, and they are usually have very low ejection fraction with very low peak exercise oxygen consumption, and also they have evidence of target organ or progressive organ dysfunction. They have recurrent presentation to the hospital. They also need usually progressive increase in the evidence-based therapies like ACE, ARBs, the blockers. Or sometimes you face difficulty in up titration of these medications. This is criteria of advanced heart failure. Sometimes you have diuretic resistance also with those patients with chronic cardiorenal syndrome. Also, you will see a requirement to add inotropes like dopamine, dobutamine in further admissions. You might see them in right heart failure and pulmonary hypertension, diminished 6-minute walk test, increased 1-year mortality, progressive renal and hepatic end-organ dysfunction, hyponatremia. Hyponatremia is an ominous sign in heart failure patients, besides cardiac cachexia and the inability to perform the usual daily activities. This is another scoring for heart failure patient during admission called InterMax score. This is developed by the Interagency for Mechanical Assisted Devices. This group classified heart failure to 7 stages. This is during the admission. The main cause of classification, this is classification for advanced heart failure patients. So we're classifying advanced heart failure patients to 7 groups. One is the worst. Those are the patients who are crashing, declining in the CCU, intubated on inotropes, on escalating dose of inotropes, and they have target organ damage, liver, kidney, and they are already in respiratory failure. Sliding fast are less severe than crash and burn, but still you need to escalate and push the inotropes every day. Stage 3 are stable on inotropes. Stage 4 are in the floor, in the cardiac ward, in and out, admission in and out, discharging home, but return quickly to be admitted. Housebound are severe heart failure that the patient is even unable to go outside his house, so housebound. And 6, there is some activity, but very, very symptomatic. We call it walking wounded. And the stage 7 are class 3B. Those patients are started to have dyspnea at rest. Recently, we call them stage 3 class 3B. Back to this again, patients who usually we put LVAD are patients in stage 3, 4, and 5. These are the patients who usually consider them for LVAD. This patient maybe he can wait on the list, but 1 and 2 usually need short-term support. This is the NYHA classification. Every one of you know we have 4 classes for NYHA class, class 1, 2, 3, 4, and the class 3 could be class 3A and class 3B depending on the onset of dyspnea at rest. This is the staging again, and the ACC staging, NYHA classification, and the informative. This is the 3 classification I have mentioned in this presentation. Next talk, inshallah, I will talk about another lecture on heart failure, including the treatment and the pathophysiology and the advanced therapies. Thank you very much.